This program is brought to you by Emory University.
So good morning. Welcome to Heart and Vascular Grand Rounds. It's really an honor this morning to introduce our guest speaker and to welcome him and his wife here to Emory in Atlanta. Professor David Wood, most importantly in his bio, his first statement is he's a cardiologist committed to the prevention of cardiovascular disease, and he truly is. He's the current president of the World Heart Federation, the founder and president of the European Association for Cardiovascular Prevention and Rehabilitation. He is the principal investigator for a study called EuroSpire, which has described cardiovascular risk and risk factors across 26 countries in Europe, and now is in its fifth rendition. He's the course director for the Imperial College Master's Degree Program in Preventive Cardiology, which he co-chairs with his wife, Katriana Jennings, a nurse who's a cardiovascular specialist. David's also the senior editor of the European Society of Cardiology Textbook of Preventive Cardiology, founded the European Journal of Cardiovascular Prevention and Rehab, served as their first joint editor-in-chief, and he is a professor at the Imperial College of London, but as I said, most importantly, has just taken on a 2-year presidency of the World Heart Federation. So we welcome him here this morning. He's going to talk about preventive cardiology as the new rehabilitation. Thank you, David.
Thank you very much, Larry, and it is indeed a pleasure and a privilege to be given this opportunity to present a grand round at Emory. And I thought, as I'm in the US, it would be good to begin with a home story with your 34th President of the United States, Eisenhower. And as I'm sure you know, he was visiting his in-laws in Denver. He had sausage and bacon and mush, whatever that is, and cakes for breakfast. He had a burger with raw onion for lunch and a roast lamb dinner with all the trimmings, and shortly afterwards he developed what he thought was dyspepsia. And he called his physician, actually he wasn't a physician, he was a surgeon, who observed him overnight, attributing his symptoms to indigestion. But in the morning he was admitted to Fitzsimon's Hospital, where a diagnosis of myocardial infarction was made. And the physician who attended him was Paul Dudley-White, who is a hero of mine. And Dudley-White had read a paper by Levine and Lown on the Armchair treatment of acute coronary thrombosis, because, as you may know, the management of myocardial infarction at that time was bed rest for up to 6 months. In fact, Eisenhower stayed in hospital for almost 8 weeks. But Levine decided to bite the bullet and to get patients up and sit them in a chair, the so-called armchair treatment. And in this observational study, he observed a case fatality during the first month after diagnosis, which was about a third of that reported previously, and in part, of course, driven by deep vein thrombosis and pulmonary embolism. So Dudley-White's prescription was a low-fat diet, an exercise regimen, because actually you become physically debilitated as a consequence of bed rest, weight restriction, the use of warfarin. And Eisenhower had been a 4-pack-a-day smoker, but had quit a couple of years earlier. And this prescription would not be far from the mark for today. And Dudley-White is often referred to as the father of preventive cardiology. Now, I don't know where you get your medical information from. I use Wikipedia, and if you look at the definition of cardiopulmonary rehabilitation, you will find that it is described as a branch of rehabilitation medicine dealing with optimizing physical function. And actually that is an extremely limited view of prevention and rehabilitation, but understandable given that its origins were debilitated patients following myocardial infarction on enforced bed rest. And if you look at the most recent systematic reviews and meta-analyses of randomized controlled trials of exercise-based rehabilitation and secondary prevention, you will see the following results. On the left are the trials of cardiac rehabilitation, and on the right, the trials of secondary prevention. Now, up until the 2016 meta-analysis, the trials of cardiac rehabilitation have consistently shown a reduction in all-cause mortality, which meets the gold standard of randomized controlled trials today. But in this most recent meta-analysis, that crown has been lost. And there is, despite that, a benefit from rehabilitation in terms of cardiovascular disease mortality, a reduction of about 26% and statistically significant, but no reduction in the risk of reinfarction. Now, on the right-hand side, you see trials of secondary prevention. And in contrast, here, there is a statistically significant reduction in all-cause mortality of about 15%. They don't report cardiovascular disease mortality, but also a statistically significant reduction in the risk of reinfarction, a 17% reduction. Now, you might ask the question, why do we have cardiac rehabilitation on the one side and secondary prevention on the other? Are these not both important in terms of the management of patients with coronary artery disease? And this subspecialty of cardiology has struggled with its terminology, and in the literature you will find all sorts of descriptions which somehow integrate prevention and rehabilitation, or is it rehabilitation and prevention, into their titles. And the term that I prefer is preventive cardiology. Preventive cardiology is the new rehabilitation. And if you read on in Wikipedia, they say that whilst the glue of rehabilitation is exercise, programs are evolving to become all aspects of preventive cardiology care. Now let me describe, I don't have US data, but let me describe the position of prevention and rehabilitation in Europe, and these data come from our EuroAspire surveys across 26 countries, in which we identify and interview and examine patients with coronary artery disease about a year or so after their acute event. And we ask the question, were you advised to follow a cardiac prevention or rehabilitation program? And there are two striking results here. One is, of course, that just 1/2 of these patients were so advised, despite the evidence from the randomized controlled trials until the most recent meta-analysis. But even more strikingly is the enormous heterogeneity in service provision between these European centres. And so in Eastern Europe and in Northern Europe, the tradition of prevention and rehabilitation is well established. In Southern Europe, not so, and actually significantly more men are advised to follow such programs by comparison with women. And if you look at the uptake, if you look at the advice in relation to diagnostic category, you will see that if the patient has had their sternum split, they are much more likely to be advised to follow a prevention and rehabilitation program. But if they present with myocardial ischemia, they are not. And actually, they all have coronary atherosclerosis. They would all benefit from prevention and rehabilitation. So why is it there is this disparity in advice given according to diagnosis? And then finally, if you look at attendance at a cardiac prevention or rehabilitation program, if the physician advises the patient to do so, then 4 out of 5 will do so. And actually the heterogeneity you saw in advice given is now much less. Patients are prepared to follow the advice of their physicians, and the gender difference is also now much smaller. So the problem lies with us, with the profession, and with the healthcare system in terms of the availability and delivery of preventive and rehabilitation. And I think there is a need for modernization because we have seen a change in the definition of acute coronary syndromes, in their presentation and contemporary management, primary angioplasty and stenting, and of course thrombolysis, early mobilization and discharge from hospital, the use of effective cardioprotective drug therapies, and actually what is the place of prevention and rehabilitation in the context of modern acute cardiological care. And I want to put the case that we need to evolve traditional exercise-based rehabilitation into a modern preventive cardiology program. Because despite all of our modern treatments for coronary artery disease, the patient at the point of discharge from hospital still has atherosclerosis. And for the most part, the drivers of atherosclerosis in terms of the patient's lifestyle and risk factors are still present, and therefore these need to be addressed to reduce the risk of subsequent events. And my definition of a modern preventive cardiology program is one which is based on behavioral science, a behavioral approach to prevention and rehabilitation, and which unites cardiac rehabilitation and secondary prevention in one program. And this is how I would define the constituent parts of such a program for patients with atherosclerotic vascular disease. And I should emphasize that we are not just talking about patients with coronary artery disease, we're talking about patients with any manifestation of atherosclerosis, transient cerebral ischemia, minor or major stroke, peripheral arterial disease. They all require a comprehensive risk factor reduction program. And that program should embrace a professional approach to lifestyle intervention, smoking cessation, diet, and physical activity, taking account of psychosocial factors and using a behavioral approach. And then beyond lifestyle, measuring and monitoring and managing all of the other major risk factors to the targets defined in national guidelines. And finally, educating the patients about the importance of and adherence with cardioprotective drug therapies for life. So, is that sufficient? Is that the extent of our service delivery in preventive cardiology? Do we just need to focus on those who have presented with atherosclerotic vascular disease? And the answer is no, because, well, for two reasons. Firstly, because the initial presentation of atherosclerosis may be sudden cardiac collapse and death in the community. And despite modern paramedic emergency resuscitation in the community, many of these patients still do not survive despite the availability of high-quality tertiary care facilities as you have at Emory. And there is a second reason, not just sudden cardiac collapse and death, But the second reason is that the initial ischemic insult may be so profound to the brain or to the myocardium that actually secondary prevention and rehabilitation has very little to offer. And so a modern preventive cardiology program will look beyond the hospital door to the community at large and to patients at high risk, asymptomatic individuals at high risk of developing cardiovascular disease. And in the US, you have your own AHA-ACC guidelines and the new risk prediction charts. This is the European score chart. They're all based on the same principle, namely, given your age and gender, whether you smoke or not, your level of blood pressure, and in this example, the level of cholesterol, it can be even more sophisticated than this in terms of the risk factors that are taken into account. But integrating all of that information, you can estimate the probability, in this example, of a fatal cardiovascular disease event over the next 10 years. So then you have a continuum of risk from low to high, and the level of risk at which you choose to intervene is governed not by science, but by the ability to screen the population, to detect those high-risk individuals, and the capacity of the health service to deliver preventive care. And in Europe, we recommend a risk threshold of 5% for fatal cardiovascular disease over 10 years as being sufficiently high to justify a preventive cardiology program. And if you're to provide these high-risk patients with such a program, what would it comprise? And the answer is it would comprise lifestyle and risk factor management and the same evidence-based medications that we offer to patients with established atherosclerotic disease. And so you may ask the question, what is the difference between secondary and primary prevention? And the answer is, of course, that an asymptomatic, high-risk individual, one moment, the plaque ruptures, and now this is a patient with an acute coronary syndrome or a stroke. And I would argue that this distinction between secondary and primary prevention is artificial, and that preventive cardiology, a modern prevention program, should embrace the continuum of secondary and primary prevention. Now, this principle of a continuum of secondary and primary prevention governed our European-wide trial, the EuroAction trial, which was conducted across 8 countries and 24 hospital and general practice centers involving over 8,000 patients and their families, patients with coronary artery disease and patients at high risk of developing cardiovascular disease. And what was unique about the program, at least for many parts in Europe, maybe not for the US, was that it was coordinated by nurses working alongside cardiologists in hospital and general practitioners in primary care, together with a multidisciplinary team, including dietitians and physiotherapists or physical activity specialists. And it adopted a behavioural approach to lifestyle change, trying to achieve the targets defined in the European guidelines. And beyond these lifestyle targets, this program also measured and monitored and managed the other major risk factors for cardiovascular disease, including the prescription of cardioprotective medications. And it was family-centered. It was family-centered because there is concordance for lifestyle within married partnerships. Like marries like, and we become more alike one another over time. So there is concordance for lifestyle within families. And taking the patient in isolation out of the family context is less effective than embracing the partner. And so we invited the patient and their partner to the program, and the partner had the same lifestyle and risk factor assessment as the patient, and participated in the program not as a wallflower standing at the side of the room watching the patient exercise, but actually doing the entire program themselves as well. And we conducted this as a cluster randomized controlled trial. In each country, we took a pair of hospitals and a pair of general practices. They were randomized to receive the EuroAction program or simply to be monitored for the usual care provided for these patients. And I want to show you the principal results for lifestyle, and the results for the hospital program for the coronary patients are on the left, and for the asymptomatic high-risk individuals in general practice on the right. And this is achieving the European targets for a healthy diet. The EuroAction program in red, and usual care in turquoise. And you can see that for saturated fat, the consumption of saturated fat by the coronary patients was significantly lower by comparison with usual care, and the consumption of fresh fruit and vegetables almost twice that of usual care, and no difference in the consumption of fish, but a statistically significant consumption, increased consumption of oily fish. And for the high-risk individuals on the right, a significant increase in the consumption of fresh fruit and vegetables. And we saw the same direction of change in the partners, and these data are yet to be published on concordance. But to explain this figure, on the y-axis you see the change in the partners, and on the x-axis the quintiles of change in the patients from low to high. So the closer you get to me, the more change the patients made, in this example, in fruit and vegetable consumption. And you can see here a very striking relationship. The patients who made the most substantial changes in terms of their fruit and vegetable consumption were associated with partners who made similarly large changes. And in terms of physical activity, and the objective of the program here was not exercise-based rehabilitation in a gymnasium setting, but to increase physical activity in everyday life. And you can see that for the hospital program, a substantial increase in the proportion of patients achieving the physical activity guidelines compared to usual care. And we saw a similarly large difference in asymptomatic individuals in general practice. And looking at concordance, again, and this is steps taken per day. Again, the partners on the y-axis, quintiles of the distribution of change in the patients, and the patients who made the biggest increase in their physical activity were associated with partners who made similarly large increases. And we felt that we had set a new standard for preventive cardiology care, embracing this continuum of secondary and primary prevention with this nurse-led multidisciplinary program. And remember that usual care here was not placebo. Usual care was the care that these patients received, optimal care by their cardiologists and physicians, by their general practitioners, and about a fifth of these patients in usual care received standard exercise-based rehabilitation. So the difference here would be even greater if it were by comparison with no treatment whatsoever. Now, I was very struck by this paper, Cardiac Rehabilitation and Risk Reduction Time to Rebrand and Reinvigorate, and Larry Sperling was a senior author on this paper, and they argue that the current model of cardiac rehabilitation, exercise-based rehabilitation delivery, is unsustainable and needs significant improvement to provide cost-effective, patient-centered, comprehensive care. And I would go one step further and say that it's not just sufficient to offer this service to patients who have already developed the disease for the reasons that I've given. We also need to extend this service to the high-risk asymptomatic individuals in the population at large. And I want to go back to the meta-analysis of cardiac rehabilitation and secondary prevention, and to remind you that in this most recent meta-analysis published in 2016, cardiac rehabilitation, exercise-based cardiac rehabilitation, has lost its crown. It's no longer associated with a significant improvement in terms of survival. And secondary prevention, this single meta-analysis improves both survival and also the risk of reinfarction. And we have just completed, and it's now in press in the International Journal of Cardiology, a new systematic review and meta-analysis of prevention and rehabilitation trials since 2010. So the most recent meta-analysis of exercise-based rehabilitation took trials up to 2010, and we have taken trials subsequent to that. But there is an important difference between our meta-analysis and that of exercise-based rehabilitation. Namely, we included all trials which addressed any aspect of prevention, not just exercise-based rehabilitation. And in terms of all-cause mortality, there was no statistically significant difference. In other words, this reinforces the most recent meta-analysis of exercise-based rehabilitation, no benefit in terms of survival. But we did find a significant benefit in terms of cardiovascular mortality, a reduction of 38%, in the risk of myocardial infarction or reinfarction, a reduction of 30%, and for the first time, a significant reduction in the risk of stroke, a reduction of 60%. But what is really interesting about these data is that we looked at whether or not these programs were comprehensive or not. And by comprehensive, I mean whether they addressed smoking cessation, diet, physical activity, blood pressure, lipids, glucose, prescription of, adherence with cardioprotective medications. And what we found was that those programs that were truly comprehensive, as defined, did achieve a statistically significant reduction in all-cause mortality, and those programs which were less comprehensive did not. And just to make that clearer, for the comprehensive programs managing 6 or more risk factors, there was a 27% reduction in all-cause mortality. For the less comprehensive programs, there was absolutely no benefit at all. And these data, I think, provide the most compelling evidence for a modern, comprehensive, preventive cardiology program. And one other observation which I think is important from this meta-analysis is the use of cardioprotective medications. And I don't know how this is managed in your services, but in the UK, the prescription and adherence and monitoring and adherence with cardioprotective medications is not managed within cardiac rehabilitation programs. That responsibility is left to the cardiologist or to the general practitioner. But we looked here at those programs which managed cardioprotective medications within the program In other words, they prescribed and monitored versus those programs which devolved that responsibility to other practitioners. And once again, we found a statistically significant benefit in terms of all-cause mortality. And just to illustrate that more clearly, those programs that prescribed and monitored medications within the program achieved a 30% reduction in all-cause mortality. Those that devolved the responsibility for prescribing and monitoring, she achieved no benefit in terms of all-cause mortality. So I think this most recent meta-analysis actually provides compelling evidence that a comprehensive preventive cardiology program, which monitors and manages patients within the program, including prescribing medications, will still achieve the gold standard of reducing all-cause mortality. And so I hope in this presentation I have been able to put a case that preventive cardiology is the new rehabilitation, that we should be moving away from exercise-based rehabilitation to comprehensive preventive cardiology programs addressing both secondary and primary prevention of cardiovascular disease as a continuum. Now, as you know, cardiovascular disease is the commonest cause of death worldwide, and 80% of those deaths are now occurring in middle and low-income countries. And heads of states met at a UN high-level meeting in New York in 2011 and agreed a resolution to reduce premature mortality from non-communicable diseases, largely cardiovascular diseases, by 25% by the year 2025, the 25 by 25 agenda. And this led to the WHO creating and publishing a global action plan for prevention of non-communicable diseases, which is leading to national action plans by ministers of health. And at the UN last September, Margaret Chan, the current Director General of WHO until May of this year, launched the Global Hearts Initiative. And this initiative is intended to improve prevention and control of heart attacks and strokes, to embrace both secondary and primary prevention, and working through primary care, through general practitioners, through nurses and allied health professionals. And we are very pleased to be a partner as the World Heart Federation in this initiative, and this was one of the reasons for my visit to Atlanta this week, was to meet with colleagues in the Centers for Disease Control and Prevention and with the CDC Foundation, who are providing the driving force for this Global Hearts initiative. I was asked by a surgeon many years ago, why prevention? A Lima graft here, a Sylvanus vein graft there, I've sorted the problem. Actually, you haven't, because the underlying disease is still there. And I didn't have a very cogent answer to his question at that time, but my mentor, Jeffrey Rose, a distinguished cardiovascular epidemiologist, summed it up simply: being healthy is better than being sick or dead. This is the sole argument for prevention. It is sufficient. Thank you.
So David, thank you very much. Again, we're very fortunate to have you here visiting with us and sharing your concepts of cardiovascular prevention and also what is going on with the World Heart Federation. In our country, we have some challenges as it relates to how we deliver health care. And although we spend more than any other country on cardiovascular treatment, we tend to talk about prevention and some of these metrics, but we tend to not invest in it at a high level. In fact, sometimes we cut costs as it relates to prevention. And one of the things I was impressed with in my visit to London in the My Action program was how, with a single-payer system, the NHS, not only did you not have the patients, drive an hour through Atlanta to get to the cardiac rehab program, but the program was taken out to the community. So you mentioned, really what caring for patients should be about is first of all, just getting the care to them, but also this nurse case managed community-based program. And so the team would travel each day of the week to a different site, and how practical the information was that they were delivering. And most of cardiac secondary prevention was being delivered at home. And so maybe if you can share, in our country right now, we're constrained because we have certain ways we pay for our services, shall we say. And the cardiac rehab payment model is stuck back in the 1970s. And so it's a barrier to rethinking and reinvigorating these important services. So maybe if you can comment what you see globally, and then thinking out of the box about the future of this, because clearly if our goal is to help our patients live better, reduce morbidity, and rehospitalization as well, we need to invest in this. So how do we think out of the box? What advice would you give us in the U.S.?
Well, I would not be so presumptuous, but the driver of the UN high-level meeting, why did heads of states debate health? They had only debated health one time previously, which was HIV/AIDS, a global, which threatened a global epidemic. But they came together to discuss non-communicable diseases because the World Bank report 2 or 3 years earlier had shown that non-communicable diseases carried a heavy economic burden on society. We were less productive as a consequence of premature mortality in what would otherwise be a viable workforce, and in disability. And that was the real driver for the UN high-level meeting. And I think if in the National Health Service, the drive for prevention is because the costs of a patient having presented once with angina or with a STEMI, the costs of that patient coming back with an infarction or reinfarction, the costs of that patient needing to be revascularized or revascularized again, the costs of this disease progressing to the point of heart failure are so great that we should be investing in prevention.
Thanks. And maybe to open it up to our attendees here, Doug. You can just take
People show me how to do this every time. But my question is I think we bring people in many times in programs, and as far as the rehab, we go on an exercise program. We teach them an exercise program, and I wonder if the better thing is not to teach them an active lifestyle and not get hung up on doing a particular amount of activities, because what I realize is when you go into particularly dealing with an elderly patient, you start trying to say, we want to do this exercise program, and they say, well, Doc, I'd like to, but I can't. My hips just bother me. And one, I'd like your response to that. And secondly, is that if you do an exercise program, you do it for a certain length of time and then cut it off. And what I worry about then is, again, the patient cuts off their whole activity level.
Well, I think you have captured this tension in the rehabilitation community very well. And when we designed our EuroAction program, we decided intentionally not to make it an exercise-based program that required a gymnasium and equipment, but to make it a program that encouraged patients and their families to become more physically active to the extent that they can in the community. But as importantly, it was also about their diet and managing their weight and controlling their blood pressure and lipids and so on. So it really was a comprehensive package. But that departure from an exercise-based, hospital-centric gymnasium program was I think, an important difference with traditional, at least in Europe, traditional exercise-based rehabilitation. It created a huge amount of controversy. I mean, the EuroAction trial, when published, was widely criticized by the rehabilitation community because we had departed from these principles. But actually, I think this is the way forward.
Thank you.
So thank you so much for a wonderful talk. If getting people to do things like take their medication or maybe make some minor changes in diet aren't so problematic. To me, the most vexing things are getting people to quit smoking and to have sustainable weight loss. I was wondering if you could comment a bit on what those two programs look like.
Yes, so the smoking story is a complicated one. But in the EuroAction trial, we achieved an absolute difference of 10% between intervention and usual care in the proportion of patients who were non-smokers at 1 year. It was not statistically significant, p equals 0.06. And although the difference was clinically important, it was not statistically significant. And we were very disappointed with that result. And when we looked into why, we discovered that the programs, the teams, had not followed the protocol. In other words, they had not used nicotine replacement therapy, bupropion, varenicline, and so on, as defined in the protocol. And as a consequence, their smoking cessation efforts were less effective. So we then did a second trial, and Katrina led this second trial, the EuroAction Plus trial. We got an independent investigator grant from Pfizer, who provided free varenicline. And in this second trial, we took patients with coronary disease and people at high risk of developing coronary disease who were willing to make a quit attempt, and we offered them the same program plus optional varenicline. And we halved the prevalence of smoking. So it was published in the European Heart Journal in 2014. So the initial trial was disappointing, but when we actually applied the protocol properly, it was successful.
David, I really love your continuum of primary and secondary, and I've always wondered if these weren't these artificial terms weren't somehow interfering with their ability to treat people. Because all our secondary preventive things seem to work, and primary prevention is, as we've defined it previously, it's hard to make that work. And if we think about it, secondary prevention defines all the people as having the problem. They've all got atherosclerosis, right? If you have had a heart attack, if you had a stroke, I mean, 100% of you have it. In the primary prevention, as we define it, it's contaminated with a lot of people who don't have the problem. They don't have any risk. They don't have coronary disease. And if we actually used imaging to identify it, we'd see, 50-year-olds with zero calcium. Okay, now there are a lot of those in those trials contaminate. Is there a reason to consider on the level of definitions somewhere to redefine what primary prevention and secondary prevention really are, and to help guide therapy? Because one of your previous presidents of the organization, Val Fuster, my colleague, loves this polypill idea.
Yeah.
And I said, well, if you're going to give the polypill to everybody in Nigeria somewhere, it's going to be very difficult because you've got people who need a great deal more intensive management, and you've got people who don't need any, and you mix all this together, and it's very difficult to prove to the world that it's working. What about another category of secondary prevention of people who've had events people have got atherosclerosis, but however you identify it, and true primary prevention of people who've never had, because your prevention is prevention of events, right? And that's a little confusing, because primary prevention sounds like you're preventing atherosclerosis, but
Yeah,
you're really talking
okay.
about preventing events, so it's a little.
Okay, so no, these are very, very important questions, and traditionally, secondary prevention is applied to those who have survived their initial ischemic event, primary prevention to those who are at high risk, and primordial prevention to the population at large. And in the European guidelines, they abandoned these terms of secondary and primary prevention. And they classified for us as clinicians very high risk patients, high risk, moderate risk, low risk. And the very high risk included those who had developed the disease, but also included patients with diabetes, which was complicated, with target organ damage, and patients with chronic kidney disease at grade 3 or 4. And then high risk was defined as based on the risk score chart, plus diabetes, but not so complicated, and CKD at a certain level, and so on. So there was a stratification of risk which did not, which brought together those with established disease and those at very high or high risk of developing the disease to be treated as one. And I think that is an appropriate clinical approach. But for the population at large, which is beyond our reach, and primordial prevention in terms of tobacco control, diet, and the built environment for people to be able to exercise and so on, this is politics. This is national policy. And I think that's where our efforts also have to be made, is influencing our policymakers to address primordial prevention as well.
Peter, you had a question?
Yeah, so thanks very much. In the Lifestyle Council of the American Heart, we agree with everything you say, but we actually like to say cardiovascular health and not prevention. So that builds somewhat on what Spencer was talking about, and to make a positive statements rather than an indirect saying they're already doing something wrong if you need prevention. The other one is these sorts of programs are great, but we have an obesity epidemic. And unfortunately, once you become obese, it's pretty hard to turn it around. We just spent $50 to $100 million on the Look Ahead trial, taking diabetic patients and trying to get them to lose weight. Couldn't get them to lose weight, and even those who didn't change their cardiovascular health very much. So this is all to be applauded, but one of the questions I do have for you, though, is what about the countries in the Euro network that aren't doing so well? And historically, the last 10 or 15 years, Eastern Europe has not done so well. Is that still the case, or are they doing better?
So to answer the first part of your question, I absolutely share your views about cardiovascular health. Our program in London is called the Imperial College Cardiovascular Health Program, for the very reasons that you give. But when addressing clinicians, physicians and nurses, allied health professionals, I use the term preventive cardiology. In the Eurospire surveys, we have been able to plot time trends over a period of 12 years now, and there has been no change in the prevalence of smoking amongst the coronary patient population. This is a hardcore of heavily addicted tobacco users. The prevalence of obesity and central obesity has progressively climbed, and in parallel, the prevalence of diabetes is also increasing. And the distinction I would make between the programs that we offer and which I have described is that to the extent that we are able to influence a patient and their family in terms of their lifestyle and manage their risk factors, which we can do very effectively, we are ultimately swimming against the tide if the environment in which we live counters healthy living. And so I am not disappointed by the fact that preventive cardiology programs have a limited impact on weight. We reduced weight by about 1.5 kilograms, waist circumference by about 2 centimeters, if I remember correctly, in our EuroAction trial. Very, very modest gains in the right direction, but very modest gains. But I don't apologize for that, because I think ultimately the only way to really impact upon weight is through primordial prevention, is through national health policies. It's a political agenda.
Thank you again, Professor Wood. We really enjoyed the meeting.
The preceding program is copyrighted by Emory University.